everyone, this presentation will be on From Novice to Expert by Patricia Benner. I'm Erin Rooney, and I'll be presenting Chapter 9, Domain Number 6, Monitoring and Ensuring Quality of Health Practices. My objectives for this presentation are to discuss what it means to monitor and ensure the quality of healthcare practices, discuss why this is important to nursing practice, identify 3 competencies related to this domain, explain how this affects the interdisciplinary team, discuss how this affects patient care, and discuss how this affects patient safety. So what does it mean to monitor and ensure quality of health practices? Nurses are often referred to as the glue that holds institutions together, whether that be a family practice office or an acute care setting. Nurses coordinate every interaction the patient has with the entire healthcare team, which we all know by this point is no small task. Nurses are prime candidates to detect and prevent errors in patient care, and these errors are often referred to as system failures. The nurse must be very familiar with the patient's chart and the patient as a person so that they are able to better identify what is normal or abnormal behavior for that patient. So the first competency associated with this domain is providing a backup system to ensure safe medical and nursing care. So the nurse may need to prevent a dangerous intervention that was ordered. The patient's condition might change, requiring the nurse to alert their physician to order additional interventions, or they could possibly need to discontinue an intervention that had already been ordered. And the patient's condition can change on a day-by-day or even hour-by-hour basis, so it's really important that the nurse is able to monitor and alter the treatment plans as the patient's condition changes. The nurse must also anticipate possible problems and how to solve them. For example, if a patient is receiving a blood transfusion, the nurse would need to know what kind of signs and symptoms to look for as far as a transfusion reaction and know what to do if that kind of reaction did occur. And the nurse also must understand the fact that anybody can make a mistake. So even if the physician is a friend or has been practicing for a very long time, the nurse still needs to perform the accurate checks and balances to make sure that everything is being done in a way that's best for patient care. So my personal exemplar related to this competency, I was caring for a patient one day who I had never met before. I was floating and I had just come on shift for the day. I had a pharmacy tech notify me that a patient seemed to be acting strange, and I realized this patient was having a change in their normal mental status. I looked in the computer and I saw that there were orders for a stat troponin and a stat EKG to be done. So I did the lab work and I did the EKG, and I noticed that there were ST elevations on this EKG. This is right about the time that we were learning about how to interpret EKGs in Nursing 331, so I had a little bit of an idea what I was looking at. When I came out of the patient's room, the resident was standing right there waiting for the results of the EKG, so I handed him the printout, and he looked at it and confirmed that the EKG was changed from the patient's baseline. So I went down to the nursing station. I found the nurse, who was also a float and had never met this patient before. Additionally, she was a new nurse, and I explained to her what was happening. I said, this EKG doesn't look right to me. The physician said it's changed. You might want to go see this patient before you go do anything else. She went to see the patient. They had been ordering things, and I noticed that this patient was not on continuous telemetry. So I said to the nurse while we were in the patient's room, do you think it'd be a good idea to have telemetry ordered for this patient? And she told me that she agreed that it was a good idea. But I noticed several interactions between her and the resident since I mentioned that to her, and she hadn't requested the telemetry order. So when I went to the nursing station and I realized that the resident was standing there, I asked him, what do you think about ordering telemetry for this patient? And he also agreed it was a good idea. And then I noticed him start to walk away without ordering the telemetry. So I stopped him and said, wait a minute, what about this telemetry order? And he was like, oh yeah, I totally forgot, and ordered it, and we had the patient put on telemetry, and she ended up being fine. But I just felt like as a senior nursing student, seeing as it was going to be my job soon to be responsible for advocating for my patients, I thought it was a really good way to start kind of practicing and talking to the physicians about things that I thought I needed to take better care of my patient and keep them safe. So the second competency related to this domain is assessing what can be safely omitted from or added to medical orders. So the nurses must use discretion when following provider orders and consider the best possible option for patient care rather than simply following the written orders. And this consists of weighing pros and cons of conflicting needs. So for this competency, I chose to use one of Patricia Benner's exemplars. It's on page 141. I'm going to read it. It states, "In the beginning, I was writing down all the times that the blood pressures were to be taken, and then I thought, hey, wait a minute, let me think about this and decide whether I need to take them or not. After all, it's not just something I'm supposed to do to make me feel better. So I stop and think, what if I know what someone's blood pressure is? What does that tell me? Do I really need to know it? Especially with some of the post-operative eye patients who have been post-op for a couple of days. We are expected to use our judgment as to when to discontinue the vital signs at night. So we carefully study the trends of the patient. Sometimes I substitute close observation so the patient can sleep." The reason I chose this exemplar is because as new nurses, most of us will be working on night shift, and weighing the pros and cons against letting a patient sleep and doing their vital signs at 3 o'clock in the morning is a decision that we're going to be faced with on a regular basis. We all know that sleep deprivation can cause delirium. So if we have a stable patient, we might choose to wait to do the 3 a.m. vital signs until we're waking the patient up at 5 or 6 o'clock to give them medications anyway. And then the third competency related to this domain is getting appropriate and timely responses from physicians. This is pretty self-explanatory. If you ask a physician for something or call a physician, you naturally expect a response as soon as possible. In order to do that, the nurse must communicate clearly and convincingly. They must be able to state what their assessment data says, what they think is wrong, and what they would like done. So it's really important to have all the assessment data collected before you call a physician in the first place. And this is a really good thing to do in order to establish your own credibility and competence. Because if you want a response quickly and if you want the physician to listen to you, it's really important that the physician thinks you're competent to make these calls for the patient. And then it's important to know when to be adamant, know the difference between what can wait until the physician rounds and what needs to be addressed immediately. And then lastly, the nurse must have a backup plan for if the primary physician is unavailable, because this can happen. A member of the trauma team may be tied up in a trauma, so the nurse needs to know who the second person to call is in the event that they need something handled right at that moment. So for this competency, I used another one of Patricia Benner's exemplars, and this one from page 142. This was a longer exemplar, so I decided that I wasn't going to type the whole thing, but you're welcome to read it. Summarizing the exemplar basically says that there was a patient diagnosed with thrombophlebitis receiving heparin therapy for 2 days at the time that the nurse met the patient. Overnight, the patient started reporting increasing pain, and the intern on call ordered IM Demerol, but the pain was not relieved. The pain continued to get worse. The intern ordered more pain medication. And when the day shift nurse came on and the night shift nurse had reported that the patient was having a bad night, was having all these complaints, and nothing was really helping, the day shift nurse went to see the patient. She found the patient short of breath, clammy, cool, restless, and having changes in vital signs as compared to where they were during the night. She called the intern, and the intern once again just wanted to order more pain medication. And now I'm going to quote part of this exemplar in which the nurse states, "In a controlled manner, I told him something was wrong with this patient and that giving him more narcotics would not solve the problem. I also said that I was calling because I wanted a doctor to see this man now. The intern came right up, saw the patient, and the patient was found to have a lung infarction." So this is a really good example of the fact that the nurse proved herself to be competent, decided that this was an issue that needed to be solved now, and she knew exactly what she wanted or didn't want in saying that this patient cannot have more narcotics and that a physician needs to come assess this patient now. And that basically ended up saving this patient's life. So why is this important to nursing practice? Nurses report that much of their time is spent identifying and preventing potential errors. And these are these events I had spoke about already, these system errors. And nurses don't appreciate the fact that so much of their time, about 40%, is spent identifying these errors, but it's crucial to their role and to patient safety. This is especially important during times with new residents. Some of these new residents may be sleep deprived, inexperienced. The nurses can have years and years more experience than some of these residents do. So they might catch things, that were ordered that could have had lethal outcomes for these patients. The nurse must make it their business to know everything that's going on with their patient. They have to know the entire chart, as compared to a cardiologist is really only concerned with the patient's cardiac function. The nurse needs to know every system of that patient. They have to know their typical mental status, and then a nurse that's uninterested or disengaged with their patients will not be able to identify subtle clues that may indicate a patient is in trouble. So how does this affect the interdisciplinary team? Nurses can be responsible for coordinating care conferences as needed. This is something that comes into play a lot in end-of-life care. So for example, if an oncologist is ordering super aggressive treatments on a patient and their quality of life is just terribly decreasing, the nurse might step back and say, okay, I think this is a really good time to meet with the patient and the family, palliative care, and see if there are kind of other options to give this patient the best chance at a quality of life rather than length of life, if that is what meets the patient's goals. The nurse also needs to clarify conflicting orders. So for example, if one doctor orders a CT scan with contrast, but the patient's on metformin and nobody discontinued the metformin, that can be terribly dangerous to the patient's kidneys. So the nurse would need to step in and say, can we do this CT scan without contrast, or do you want to reschedule it and we can hold the metformin for a couple of days prior to the scan? And then nurses are responsible for promoting efficient communication between the entire healthcare team. How does this affect patient care? So patients often fear that they will get lost. So if a nurse is there to kind of facilitate communication and advocate for the patient, typically their care will be better and their anxiety will be eased in the meantime. This also can instill confidence in patients. So patients that are extremely ill or recovering from very serious surgery may start to feel hopeless that they will never reach their goals or never return to their baseline functioning. Something we know that's so simple for patients that can help them in so many ways is deep breathing. But after, for example, open heart surgery, pain control might stop them from deep breathing. So the nurse can really work with the patient to create a plan to medicate the patient for pain and then practice deep breathing exercises while the patient's more comfortable. And this will help them feel like they can achieve these small attainable goals, which in turn will help them achieve their long-term goals for recovery. Effects on patient safety. So knowing what's normal for the patient allows the nurse to pick up on subtle cues that something is wrong. So for example, if you have a confused patient who you've been taking care of for several days, you may notice a level of confusion that is more so than what is normal for that patient. That can alert the nurse for an increased risk of falls. The patient may need a one-to-one, increase hourly rounding, place the patient in a room near the nursing station, and see what's causing that increased level of confusion. Maybe the patient has a UTI that they need antibiotics for. And this can also avoid causing harm to the patient. So if a patient has an order for a beta blocker and they don't have hold parameters, the nurse may call the doctor and ask for hold parameters before administering the medication. Here are my references, and thank you for watching.